You are welcome to my channel. Thanks for visiting. If you haven't subscribed, please remember to do so. Today, I'll continue on infective endocarditis, but the emphasis will be on pathogenesis, the microbes, vegetation, and mycotic aneurysm. Without further ado, let's go. Now, the brief anatomy of the heart is necessary, particularly as it is related to the endocardium, the myocardium, and the epicardium. Remember, the topic is infective endocarditis. So, if you want to know more about the endocardium, how it is related to the heart, then click on this very link. There I have given detailed explanation. We will not be able to understand the pathogenesis of infective endocarditis thoroughly without going through the associated risk factors. For you to get that, here is the link. If you click on this, you will find all the possible risk factors associated with infective endocarditis that is known as of today. Now, the pathogenesis proper. Let's go through the scenario where there's damage to the valves or endocardium. And this could occur by jet lesions from turbulent blood flow. And that will be leading to endothelial and valvular damage. Note this. These account for the reason why we have infective endocarditis at the regions with more force or pressure of blood reaching them, like the septa and ductus arteriosus. So an individual with risk factor like ventricular septal defect and patent ductus arteriosus do suffer more than individuals with atrial septal defects. And why that? The jet lesions, the force reaching those regions will be greater than the force reaching atrial septum. Then we'll also find out that the valves, the native valves, could be damaged when there are certain procedures with certain devices like catheterization, insertion of electrodes. All these could damage the native valves, but there may be prosthetic devices also, implanted, okay? And then prosthetic valves can be in place after replacing, natural valves that have already been damaged. So when we have all those, then the valves are already damaged, opening the ground for something else. Then solid particles from example will include intravenous drug use, or sometimes because of autoimmune conditions, and sometimes because of degenerative valvular lesions. The valves could be in trouble. So we've seen that the valves have been damaged, or we have prosthetic valves with localized clotting occurring. The localized clotting will occur, and that will give us a condition known as non-bacterial thrombotic endocarditis. The blood clotting here will involve platelets and fibrin formation. They will both facilitate or enhance the process of vegetation. I will go through everything on vegetation in a bit. But if the host immune system is strong enough, It will fight off the vegetation, and there won't be signs and symptoms. If the host immune system is not strong enough or is overpowered, then we are left with signs and symptoms of infective endocarditis. Like I've said, the host immune system will determine whether or not we'll have signs and symptoms. For you to understand better what I meant by host immune system and all signs and all symptoms of infective endocarditis, please kindly click on this very link. That will take you there. Now, more info on vegetations, but this is different from the vegetations you are familiar with. I'm not talking about grass or trees. I'm talking about cardiac vegetation. In this case, it is going to be the unnatural or unwanted abnormal growth, simply put, a mass that is formed from fibrin, platelets, and bacteria, all glued together by agglutinin antibodies that is produced by the bacteria and at the infection site. It is mostly found on the valves or on the endothelium. And the first will include that it's going to destroy the valves, leading to regurgitation. And of course, the hallmark of infective endocarditis is the presence of inflammatory changes in valvular tissue at the site where these vegetations will be attached. Somebody will say, you've described this hallmark, why bringing it out? I just love to bring it out so that it will be clearer. The hallmark of infective endocarditis is what? It is the presence of inflammatory changes in valvular tissue and the site of vegetation attachment. It could be at the endothelium as well. So, the host immune system will then determine what follows. If it's strong enough to now wipe it off, great, no signs, no symptoms. If it is overpowered, then there'll be signs and symptoms. The microbes. The pathogenesis taking us through the fact that there'll be vegetation. And remember, I've said that vegetation is an unwanted mass found on the valve or prostatic valve or the endothelium. The component of that vegetation is that of fibrin, platelets, and bacteria. The bacteria there is what we're about to go through, although we'll go through fungi also. But depending on the symposium, the lecture, the seminar, or the textbook you are going through, 80 to 90% of infective endocarditis will be caused by bacteria. So it is noteworthy to spend some time to study the type of bacteria that could be involved in infective endocarditis. And to start with, let's see, Staphylococci group. Here we'll be focusing on Staphylococcus aureus, coagulase negative staphylococci. When it comes to the Streptococci group, there may be viridians with S mutans, S sanguinis, and S milis. Group D is strep, like S bovis, that was the former name. It is now known as S gallolyticus. That is Streptococcus gallolyticus, and even S fecalis. Then we will also talk about enterococci. Other bacteria that could be causing infective endocarditis but not very common will include Escherichia coli, strep pneumoniae, Haemophilus influenza, Coxiella burnetii, Brucella. The list will also include chlamydia, Bartonella, Legionella, even Trophima whipple, and Mycobacterium tuberculosis. Fungal infection is another possibility that is not very common, but is worth mentioning that fungi could be responsible as part of the microbes causing infective endocarditis. And there's a group known as HASEC, is a form of abbreviation. H for Haemophilus acrophilus, A for Actinobacillus actinomycetes semitans, and C for Cardiobacterium hominis, E for Echinella corrodens, and K for Kingella kingae. Non-Haeckel gram-negative bacteria, or sometimes could be as a result of polymicrobial agents. Sometimes we do run into trouble of false positive results from the lab, and that could occur. Having false positive infective endocarditis, that could occur with Cortibacterium, formerly known as Propionibacterium acne, also with Bacillus species or coagulase negative Staphylococcus, including Corynebacterium species. Just in summary, the common ones will be Staphylococcus, Streptococcus, and Enterococcus. And like I said through the introduction, that will account for close to 80 to 90% of causative agent of infective endocarditis. That is why some authors are comfortable to call infective endocarditis bacterial endocarditis. But rarely we can find fungi being the culprit. Coliforms could be responsible, Pseudomonas or HACEK group. The most dangerous of all the bacteria when it comes to infective endocarditis would be Staphylococcus, specifically Staphylococcus aureus. That will be the most virulent or fulminant and is responsible for acute infective endocarditis. The Streptococci will be responsible for subacute endocarditis. It is noteworthy that S. epidermidis is coagulase negative, affecting the prostatic valves. Although very rare, when it occurs, it's very aggressive with high mortality. Now, let me quickly delve into nosocomial infection when it comes to infective endocarditis. And specifically, I'll be talking about Staphylococcus epidermidis. It is a coagulase negative staphylococcus, and it could withstand salt, so it could be found in marine environment, mostly hitting hard on people with decreased immunity and anyone with catheterization. The catheter that goes into the vessels, getting to the heart, affecting the prostatic valves a lot, and it is nosocomial because it is healthcare associated or hospital acquired. The reason why I've decided to touch this separately is, though it is very rare, but pretty aggressive with high mortality. I cannot just shy away from that. Then The Streptococci, once again, the group D, strep and viridans, will affect the prostatic valve. They will likely be responsible for less trouble compared to Staphylococcus epidermidis, so they can cause acute infection. Particularly and specifically, we should remember that it could be involved in gastrointestinal tract troubles, for example, colon carcinoma. So just like the enterococci, they can also be involved in trouble with the colon. The reason why colonoscopy becomes necessary in anyone with infective endocarditis. But in addition to that, the alcoholism is going to be a risk factor in this scenario. The Enterococcus group will include Enterococcus faecalis and Fusarium. These will be affecting the colon. That is why we can have colonoscopy. Now, why monitoring the treatment or from the beginning of the diagnosis, you have colonoscopy because of this. It's going to be responsible for acute endocarditis, not acute fulminant or virulent endocarditis. No. Now, culture negative infective endocarditis. Let me quickly go through the agent, then I'll talk about how we can get here. The agent possibly responsible for this will include Trophirima whippley, that gives Whipple's disease. Zoonotic or history of contact with animals is necessary here. Coxella bonanti is a possibility Brucella species. They are both fastidious zoonotic agents. It may be as a result of fungi or HACEK group. But if you incubate the HACEK group for a longer time, as long as 5 to 7 days more, you will likely get the exact agent involved. Now, how can we get to culture negative infective endocarditis? If after 7 days of incubation and all the 3 sets of samples taken are negative, then we can be thinking of number 1, either antibiotics have been given earlier and that has prevented the growth of the agents, or we are dealing with fastidious, meaning that the bacteria with fastidious characteristics, meaning it's going to require or it's going to be demanding more stuff to grow. Or we are dealing with intracellular bacteria that cannot be cultured with the standard methods. But in this individual, fever will persist. The echo would have confirmed vegetation or abscess. Some would have even come down with complications like stroke. And then going through the peripheral stigmata of infective endocarditis, you are more than sure that you found that already. And then through auscultation, new heart murmur is peaked or there's heart failure already. Then what are we going to do in this scenario? We will embark on serology. We'll go and look for polymerase chain reaction to get our diagnosis. Mycotic aneurysm. By definition, ironically, it is not a fungus, infection. Its etiology does not include fungus in any shape or form. Some actually call it bacteria or infected aneurysm. It's a microbial arthritis. Okay, the risk factors here will include IV drug use, yes, and any condition that could decrease immunity will serve as associated risk factor. It is caused mostly by Staphylococcus aureus. but it could also be caused by Salmonella, Klebsiella, Escherichia coli, Proteus, and Yersinia. It is going to spread through the blood, that is hematogenously spread. And this could lead to dilatation of the affected atrial wall. It's going to resemble the fleshy fungus. And that is why the author of this phenomenon, that is William Osler, described it as such, because he found multiple aortic aneurysm that he described in those days. Mycotic aneurysm can be found in femoral artery, the aorta, splenic, intracranial, and superior mesenteric vessels. With that, I've come to the end of this short presentation on pathogenesis, the possible microbes, vegetation, and mycotic aneurysm. This will help us as we move on, in understanding infective endocarditis, the signs and symptoms, how to make accurate and appropriate diagnosis, and appropriate treatment. Thanks for listening. Remember to subscribe to my channel. Remember to share this with all your friends. I appreciate it.